Hello.
Yes, it's working, sir.
Yeah.
It's working.
To us,
Yeah.
start.
Today, good afternoon, Dr. Vrajesh, Udani, Dr. Ketkar, sir, Dr. C.P. Bansal, so many of my seniors, colleagues, and juniors who are right now attending this Zoom meeting, as well as uh, the YouTube meeting. Uh,
I
at
didn't
the
get
very
that.
outset,
Could you try again?
at the very outset, may I request Dr. C.P. Bansal to welcome Dr. Vrajesh and
Yeah.
start rolling.
You start, huh?
Yeah.
Thank you so much, Swas. Good evening, everyone. It is my indeed a great pleasure to welcome you all to Gwalior Webinars episode 4. Today's topic, why, when, and how to choose AEDs, is not just relevant, but it is very crucial. We deal with epilepsy day in and day out in our clinics, but many of us still face doubts: which drug to choose, when to stop the treatment, when to add another drug, and so on and so forth. And finally, what to do when seizures doesn't respond. दोस्तों, आज का सत्र इन सभी सवालों का समाधान है, और समाधान भी साफ, व्यवहारिक और भरोसेमंद. We are truly honored to have with us the best in the country, Professor Dr. Vrajesh Udani. Dr. Udani sir is a living legend in pediatric neurology, a teacher of teachers, an astute clinician, a clear thinker, and a brilliant speaker. I think he has this rare gift of making the most complex ideas look very simple. हम उनके शब्दों से सीखने का सौभाग्य प्राप्त कर रहे हैं, ये निश्चित रूप से हमारे लिए गर्व की बात है. We also take pride in welcoming our special guests for the function today. Dr. Dinesh Laruya, a senior pediatrician from Delhi, a respected name in our fraternity, and my own classmate from GR Medical College, Gwalior. We are delighted to have him with us today. Dr. Sudha Rao, Head of Pediatric Endocrinology at Wadia Hospital, Mumbai, a proud alumni of our GR Medical College. She continues to inspire us with her brilliant academic achievements and dedicated in field of endocrinology. I extend a warm welcome to both of you and all our esteemed guests joining from outside Gwalior. Presence of Dr. Gupta sir, respected Dr. Gupta sir, in fact is very inspiring today. Sir, your presence truly enriches this academic exchange.
Thank you.
To our young pediatricians and postgraduate students, I say that this webinar is really important. Please do not miss Gwalior webinars. दोस्तों, ये सिर्फ लेक्चर नहीं है, ये एक अवसर है अपने ज्ञान को गहरा और स्पष्ट बनाने का. I also take this opportunity to thank the entire core team of Gwalior webinars and office bearers of Academy of Pediatrics, Gwalior Academy of Pediatrics, as we say, GAP. Your consistency, dedication, and academic spirit are what which makes this series so special. हमारी श्रृंखला तभी सफल है क्योंकि इसके पीछे एक समर्पित टीम खड़ी है. I will not take much of your time. Over to Dr. Suhas, and thank you once again, sir. Let us begin the exciting session and brilliance of Dr. Vrajesh Udani, sir. Thank you.
Thank you.
Thank you very much, Dr. C.P. Bansal, sir. May I now request Dr. Anand Ketkar So kindly take the program forward. Dr.
Thank
Ananthi.
you, Suhas. It gives me an immense pleasure to introduce our esteemed speaker, Dr. Vrajesh Udani. He is born with inherited genes of pediatrics from his father, Professor P.M. Udani sir, who was leading pioneer of pediatrics in India. Fortunately, my father worked under him in JJ Hospital, Mumbai, and I had an opportunity to attend his clinics and listen to him in various conferences. Dr. Vrajesh is continuing the legacy by following those footsteps. If I narrate his work in details, I think I will exceed him. So, in short, just to summarize his proficiency, he did his education MD, MBBS and MD from Grand Medical College in 1981. Then he went to States for his neurophysiological diploma in American Board of Clinical Neurology. He did his diploma in neurology and uh, fellowship over there. In professional experience, he has a wide knowledge and has the experience of last 36 years as a consultant in pediatric neurology in PD Hinduja National Hospital, Mumbai. He is honorary assistant professor at neurology department, Grant Medical College, consultant by Jerabai Vadia Hospital, Mumbai. His clinical work is focusing in managing the children with various neurological conditions, especially in complicated epilepsies and seizures, neurometabolic disorders, autism, and he has a child development clinic in SRCC Hospital, Mumbai. He enjoyed the president's of AOCN from 2016 to 2018, as this is the Association of Child of Neurology, Pediatric Neurology. He was also a chairperson and organizing secretary of ICNC, that is International Child Neurological Conference, which held in Mumbai, and he's the president of CNG. He has published more than 93 papers and articles and 30 chapters in various journals and chapters in textbooks in the topic of pediatric epilepsy and neurological disorders. He is outstanding speaker, as we'll come to know, in various national and international conferences. He has given 8 prestigious oration like Merchant and others in his special interest in epilepsy, and which he will enlighten us today. Please join me in welcoming Dr. Vrajesh Udani sir as he delves into the critical subject of epilepsy and most the practical issues which we face, how to treat it. Sir, I welcome you again.
Sir,
And
I will just like to add one thing. Dr. Udani sir has received Shantilal Seth oration also way back in 2014, just the year, 1 year before my presidency. And he has also received Lifetime Achievement Award in 2025. So, thank you. We are really fortunate to have him today, sir.
Yes.
Thank you very much. I'm not sure I mean, I deserve all those many things you said about me. Thank you for your invitation. I just hope that we can sort of interact more than just me giving a didactic lecture. Uh, I would like to tell you that my lecture is more of a practical approach to how to use medications, anti-seizure drugs in epilepsy. And there are many examples, and I don't know how many Do you have any residents and fellows, or these are anybody attending? Or hello,
Most
can
of
you hear
us,
me? By the way,
yeah,
Yes,
yeah,
you
we
are
can.
audible, sir.
Most of us,
questions. If anybody wants to, just give their opinion, it'll be great.
yeah.
Okay, so I'll just share my screen. It's not turned on. The host has to allow me.
Allowed, sir. Kindly try.
Yeah. Can you see?
Not
No,
yet,
sir.
sir.
Share. Okay.
Yeah.
Now
Yeah, perfect. Yes.
I think there are two devices open. Okay. So I've just titled this. There's a two devices open somewhere. Can you shut off one device? Hello. Has anybody have two devices?
Is it open at your place, sir? Is it open at your place? The echo
No, it's
coming
not.
from.
No, I don't have any. I only have one device. Can you hear me?
Yeah, we can hear you clearly now.
Okay. So I've basically given this title because there are lots of questions which are practical, but I thought I'd just first make sure we're all the same page when we talk about epilepsy. So the first thing is, of course, what is the definition? And this was a long time back, but we know an epileptic seizure is a transient occurrence of signs and symptoms. This is what we see. Now, it's supposed to be abnormal, excessive, synchronous neuronal activity in the brain, but this is not what we see. We only see a transient occurrence of signs and symptoms, which can occur in several other conditions as well. And this leads to changes in motor or sensory or behavior, consciousness, emotion, etc., which we clinically see and we wonder whether it's a seizure or not. The term convulsion is now outdated and we use it only in the context of motor seizures. Epilepsy is a different ball game. It's a disorder of the brain characterized by the following. This is an important enduring predisposition to generate epileptic seizures. In other words, the circuitry in the brain has changed and now epileptic seizures can occur without any provocation. It also has consequences. There's neurobiologic, cognitive, so many of our kids are mildly having learning problems, etc., psychological, which results in behavior disturbances, and social because of other reasons, like example, stigmatization, etc. And the definition of epilepsy requires the occurrence of at least one epileptic seizure, which all of us know. In the past, it was thought to be that you must have two epileptic seizures. So I'll just come to the new definition now. So the operational definition, which was changed in 2014, quite a while back, is at least two unprovoked or reflex seizures occurring 24 hours apart. Say, for example, you have two photosensitive seizures. That's also accepted as epilepsy, more than 24 hours apart. Most of you are familiar with this. And the other thing is one unprovoked or reflex seizure and a probability of further seizures similar to the general recurrence risk after two seizures. So, after two seizures, the risk is 60%. If you have one unprovoked or reflex seizure and your risk is 60%, and we'll find out how, then it can also be considered epilepsy. And the diagnosis of an epilepsy syndrome. Now, how do you find out whether the risk is 60%? If there's a MRI abnormality, an EEG abnormality, and a clinical abnormality. The second thing which has changed over the last 3 decades or 4 decades is the focus is no longer on the epileptic focus. So this is this is a scan with a Sissy circus, live Sissy circus, which is at that time was called a focus. This is an epileptic focus. Then this went on to have what is called the epileptogenic zone. So the actual seizure onset occurred from this gray area. This potential area was gray, and then all this area also was involved in the epileptogenic zone. And if you removed all this entire zone by surgery, you would be theoretically seizure free. Now it is called the epileptogenic network. So we know that it is not the focus, it's not one area, it's not a zone, which is, of course, a very small area, like for example, is seen over here, but it's also a network which involves multiple lobes. And therefore, they may have a lesion over here, the epileptogenic zone may be here. This is the propagation network. So the whole thing is a epileptogenic network. And this is important because now we consider generalized seizures as bilateral network activation. So it is not starting together from one side. It is just that there's a bilateral activation of epileptogenic networks bilaterally. And because of that, you see a generalized seizure. And a focal seizure starts over here, goes to the opposite side, and you may have a generalization as well. So these are the type of things which you can see in a seizure. This is how you understand epilepsy. In 2017, our old definition, of the classification of seizures was changed. And just to tell you, in 2025, just a month ago, it has been changed again. So, it's been changed almost 3 times this last 25 years. And therefore, it's important to keep up with it. But I'm going to stick to the 2017 because it's more, everybody's more in tune with it rather than the new definition of classification of seizures. So you either have focal onset, generalized onset, and sometimes you don't know because you might see a seizure or the witness may experience or see a seizure from the middle of the seizure. It has to be either aware, so he's aware of what's happening, has memory of it, or impaired awareness. He may be motor or non-motor, and may be focal to bilateral tonic-clonic. So this is how you describe a seizure. Generalized onset, motor or non-motor. There's nothing like you have to be impaired awareness in a generalized seizure. And unknown onset, of course, is the same as a generalized. The fourth classification is unclassified, where you don't know at all because nobody has seen it. And this is based on clinical, EEG, and imaging, and you can use it at any level of expertise. So, for example, if you're an epileptologist, you may want to know all these details of how exactly the motor onset, whether it's an epileptic spasm or a hyperkinetic seizure, or non-motor, for example, is an emotional seizure, etc., etc., etc. I don't want to go into details of that. The old thing about secondary generalized tonic-clonic is now changed to focal to bilateral tonic-clonic. That's important. And in generalized, you have the motor, for example, myoclonic, epileptic spasms can be also focal, which is always thought to be a generalized, but has all changed. Then the epilepsy also got classified. So you have the first thing which I've already discussed, the seizure types. Then you have the epilepsy types, which can be focal, generalized, combined, generalized, and focal unknown. And then epilepsy syndromes, which are very specific. So these are actual diseases of epilepsy, which may have a genetic causation. And then not to ignore the etiology. The etiology could be many of these structural, for example, perinatal brain injury, genetic with a number of genetic disorders which are now come, or presumed genetic, infections like Sissy circus, metabolic like say MSUD, immune like autoimmune encephalitis, or Rasmussen's encephalitis, and then finally unknown. And then also the comorbidities are included. So we know whether the patient has learning problems, autism, etc., etc. Now, before we start treatment, we will be reasonably sure it's definite seizure. So EEG, MRI do not diagnose epilepsy. Only a careful history from an eyewitness will help in the diagnosis. And that's why you must sometimes even call up the teacher or something if the parents haven't seen it. Videos, of course, has made things very easy now. So what are the characteristics of seizures? They are usually brief, less than 90 seconds. They are often the same kind of semiology or what you call characteristics. They often come more in sleep than in awake. Eyes are open, either to one side or staring, sometimes uprolled, unresponsive, post-ictal, and then, of course, certain things like tongue bite and incontinence in a motor seizure, almost certainly a seizure. But many of these can occur in other conditions as well. So you have to determine the recurrence risk if untreated. So if it is 30% or below 50%, do not need to treat. If it is higher than that, you probably do. So this is example jerks. These kids are basically benign neonatal sleep myoclonus occurring in a baby who is sleeping, doesn't occur in the awake state, and is definitely not a seizure. His eyes are closed over here. This is a shuddering attack which looks like an infantile spasm and can be mistaken. It can come in clusters like infantile spasms do. But you must be, if you've seen a video, you're not, this one is happening continuously and one after the other. Then generalized motor episodes. This baby is getting crying. Of course, all of you are very familiar with this. And then gets stops crying, becomes unresponsive. This is a breath holding spell. And this is a self gratification behavior which happens in females very often when they are just about to sleep. And this is, of course, all of you are familiar, but these are things which you should always rule out, especially the younger residents or somebody who's ever attending this. The other thing is seizures can come as drop attacks. So it can come as jerks, it can come as drop attacks. And the drop attacks typically, for example, this is a patient who had a drop attack, but it's a psychogenic one, what was called pseudo seizures. Now it's called non-epileptic drop attacks. And you see, I'm putting a tuning fork, and I've told the child that this will help bring the seizure. And he gets the seizure just now, just fast forwarding it. There he goes, drops, and there he goes. So, you can make this diagnosis in front of the parents, and they'll also understand that this is not really a seizure, it's psychogenic. This is, of course, a child, or rather a young woman who has convulsive syncope. So you must know that syncope, or where you have loss of blood pressure, can sometimes come with clonic movements, which is actually a hypoxic seizure. But this is not epileptic. And of course, this is a young-year-old boy who had so-called generalized tonic-clonic seizures only when exertion, and he had prolonged QT interval cardiac syncope. In nocturnal attacks, usually are seizures, but often you may get a parasomnia. So for example, this is a boy who got up.
No, not there, not there.
He's conscious enough that he's crying. He's following instructions partly. There's no awareness of this episode. So this is a night terror, which you can see. While this is, can you tell me what this is? This child also used to get up in the night, to walk around and do the same things every time, as if looking for something, hyperkinetic. She would become agitated if she was restrained, and then she would become okay. So this was a hyperkinetic seizure. So even these are, so this is, often it's difficult to differentiate between these two. So what do you expect when you treat epilepsy? you only reduce the risk of recurrence. So, one thing is not disease modifying, it is just a symptomatic treatment. Obviously, it avoids, improves quality of life. It prevents anxiety that any time a seizure might come. So, it's obviously required. But you must understand that it does not influence long term seizure outcome. And 70% of childhood onset seizures, which is between 5 and 10, will remit by 2 years. After adolescence, it's much less. So, epilepsy diagnosis only if recurrence risk is more than 60%. So, treatment is not automatic, it's individualized. It's not, you don't have to treat if it's a seizure, but it needs to, if it's a once in a year seizure, epilepsy, you might wait. It's not a problem. So there's some very simple examples. 7-year-old boy brought to casualty for one episode, fell down in class, started shaking, and then was okay. Family history was positive in father, epilepsy in paternal aunt, routine EEG, normal, MRI, normal. Do you treat? I'll just answer myself, I think. You don't treat. Recurrence risk is low over 2 years. So you don't have to treat. Case 2, fifth episode of febrile seizure, so very frequent. Normal examination developed. Do you treat? No. Simple and even complex febrile seizures do not need investigations or treatment. 3-year-old recurrent complex febrile seizures, some are prolonged, some are focal, and they are basically, this could be epilepsy, what somebody might call a fever trigger epilepsy. You're not sure because it's a febrile seizure. It's coming only with fever. But there's a neonatal seizure on day 3, and then I think you investigate. And you find the MRI shows gliosis and the EEG shows occipital spikes, and therefore you're quite sure that he probably had a hypoglycemic injury, and you may or may not need treatment. You may not treat him. You may still wait that he gets an unprovoked seizure without fever, but you at least tell the parents that there's a high chance of getting seizures. This is a 6-year-old normal girl, got up from sleep, woke mom up, could not speak, was drooling, then slept, past medical story, similar episode 16 months ago, and EEG spikes in central region. So this is a patient who has normal kid, school age, gets up and gets this twitching of the mouth and spikes in the central region, what is called Rolandic seizures initially, and now it is called self-limiting or benign focal epilepsy. And they're usually infrequent. There's a low chance of status epilepticus, and most of them are sleep related. So you can wait because it might be one in months only, or once in a year, or sometimes more, but usually self limiting. What about the first seizure where there's no syndrome? The last one was a syndrome. So we know the actual prognosis, what's going to happen. But suppose you have a first seizure and just nothing else. So when you start treatment for, you might consider treatment. One is status epilepticus. So nasal midazolam is also okay. If you don't want to give long-term treatment, you say, okay, give him precautions for nasal midazolam, even that's fine. But status epilepticus sometimes has a higher chance of a repeat status, so you may want to treat. High chance of recurrence, like I already said, if you have perinatal brain injury or tuberous sclerosis, daytime seizures in older or independent adolescents, she's going by train, going to school, and they don't want any restrictions. The risk in older age group means going away by itself is very unusual. So 70%, 80% of patients who start epilepsy in adolescence will persist. That's why you may want to treat. And caregiver preference. Sometimes the parents just want it. Don't argue too much because sometimes, you tell them that in your opinion, you don't need to treat, but then they let them decide. Now, the efficacy of different AEDs or ASDs now in childhood newly diagnosed epilepsy is all equally effective. So in 1996, there were all these 4 valproate, carbamazepine, phenobarbital, all equally effective. But the best tolerated, VPA and carbamazepine, so valproate and carbamazepine. 2007, focal Surprisingly, lamotrigine was better than the rest because efficacious but least side effects, better than carbamazepine, topiramate, etc. Generalized and unclassified, valproate was better. So everybody seems to agree on one thing, that all more or less older drugs are as good as the newer drugs, except the last one, which showed that valproate in generalized epilepsies was actually better than levetiracetam. And we know that levetiracetam has become the ASD drug of choice because it's easy to use, you can use a full dose and all that. But the point is that it is as effective as all the other drugs, and most importantly, valproate is more effective in generalized epilepsy. So, to comment on this, is a focal you can use either carbamazepine or oxcarbazepine or lamotrigine. But remember, lamotrigine, I tell you what the problems are with it. Generalized valproate, and in early epilepsy for neonatal, etc., phenobarb was supposed to be the old drug, but now, of course, levetiracetam has become the drug of choice. So which AED depends on epilepsy characteristics, seizure type, epilepsy syndrome, how frequently are the seizures, the disease. Patient characteristics, age, gender, comorbidity. Is the child obese? Is the child hyperactive? Is he autistic? Concurrent AEDs, allergies, etc. AED characteristics. So, is it a broad spectrum AED or ASD, or is it a narrow spectrum? Can it be started at full dose, or you have to go slowly? How many times a day do you have to give it? Is it in the pill form or liquid form? And others. And the most important others is the first two, cost and availability. This is very important in our country. So there are the two broad types of AEDs, broad spectrum, effective against almost all types of epilepsies, and focal and generalized, and unlikely to exacerbate seizures. And the other one is narrow spectrum, against only a restricted range of seizure types, focal or generalized. It's not focal and sometimes if you use the wrong drug, you may exacerbate seizures. If you use, for example, you use carbamazepine in a generalized epilepsy, you may worsen it. In broad spectrum, the three important, the ones in red are the ones which are usually used. So broad spectrum are valproate, lamotrigine, levetiracetam. The ones in blue also can be used initially, but they are only used occasionally. These three are the ones which are used, and the other ones which are not, which are in black, are rarely used by pediatricians. Narrow spectrum, again, the red ones are the ones which are used, carbamazepine or carbazepine, and phenytoin, vigabatrin are much less used in focal seizures, but they can be used. And the others, recently, lacosamide is becoming more and more popular, though again, you have to have experience with these drugs. Narrow spectrum is exactly for absence seizures, is ethosuximide. So you can't use ethosuximide if your absence has generalized tonic-clonic seizures, because you will precipitate the tonic-clonic seizures, though you might control the absence. So broad spectrum, if you're not sure, can be used effectively and safely in most epilepsies. What would you use in this case? This child has a cluster of asymmetric spasms, and there's a ash leaf spot, which tells you that this is a tuberous sclerosis, and therefore the first is the infantile epileptic spasms due to TS, first line ACTH or high dose prednisolone for infantile epileptic spasms, but in TS, you only first choice is vigabatrin. Recently, people are using in both. So again, in TS, use vigabatrin. In all other types of infantile spasms, ACTH or high dose. High dose means 4 milligram per kilogram per day. And nowadays, people are using it together because it gives, and this is an emergency. You must treat this rapidly, otherwise you might, develop autistic behavior or retardation. This is a patient who is hyperventilating, gets an absence attack.
पीला याद कर पीला याद कर
And the drugs which can be used in all these are these ethosuximide, valproate, lamotrigine, zonisamide.
क्या
But we know that the first line is ethosuximide and valproate, but ethosuximide is preferred because valproate has got more side effects. So whenever you're checking out which one to use, it has to be effective in controlling the seizures as well as having least side effects. Second line is lamotrigine. Third line is zonizumab. So generalized tonic-clonic, I've given the important two first stops. Generalized, use VPA, LTG or LEV. Focal, use LEV, oxcarbazepine or VPA. Use VPA in younger kids because the others might precipitate generalized seizures. Second line, clobazam. Third line, you may use an infant's phenobarbital. Myoclonic atonic, use valproate. Forget the rest. Myoclonic, etc. is not important, but valproate and of course clonazepam, clobazam, levetiracetam are good. Tonic seizures again valproate. So you can see that valproate, lamotrigine, and levetiracetam are used in many of these, and therefore these three are the ones which are used maximally. Why don't we use phenytoin? It's a good drug, it's a cheap drug, but the problem is its low levels are, very difficult to get the levels. So you can sometimes go in the same week from a low level to a high level, and vice versa. And therefore, low level you're out of control, and slightly high you're toxic. It's very narrow range of efficacy, 10 to 20 milligrams. Drug interactions, it's a transducer of liver enzymes, and you get very problematic. So you can't use it in combinations. Poor absorptions, and you may have to give it 3, 4 times in infants. Liquid preparations, which are will give you more fluctuating levels, especially in small children. You have to do frequent blood levels. And most important are long term, irreversible side effects like cosmetic, you become hairy, you get a coarse face, cerebellar ataxia, of course, and become cerebellar atrophy. So we don't generally use this in children, except in the acute stage. Adherence to medication, only 20 to 70% adhere in Indian studies. And this is most important reason is cost and availability, poor knowledge, not being given enough counseling that this is a long-term treatment, you cannot stop, what are the dangers of stopping. All this is not done usually, especially in small towns and villages. And using new AEDs in rural towns and villages is very dangerous because half the time the chemist doesn't have the drug. So this is something which you should keep in mind. I got some 2, 3 cases. But do I have time, or should I go on to the questions?
Please,
Hello.
please continue.
Yeah. So this is a 12-year-old girl. In the morning, she gets up. She's clumsy. She drops her tea, her toothbrush. She has severe headaches. It's been called migraine. EG has spikes generalized. MRI is normal. She's quite obese. She's 72 kilos, and she's had recently menarche, which is still irregular. What do you do? No treatment, wait and see, valproate, lamotrigine, levetiracetam, topiramate, So the question over here is, this is most likely a genetic generalized epilepsy, what is called JME or one of those types of epilepsies, which comes in the uh, adolescence. It happens in girls. So you don't never use no treatment because this is something which will always recur. Valproate don't use because weight gain will occur. Develops a metabolic syndrome. She has PCOS. If she has to continue this drug for a long time, it may be teratogenic. It is very teratogenic to the fetus. Lamotrigine can be used. It affects generalized tonic-clonic very well. It's weight neutral, but it doesn't affect myoclonus very much. Levetiracetam and zonizumab are both good. It affects the GTC and the myoclonus, and zonizumab in fact causes weight loss. But topiramate would be the drug of choice over here because it works against all three: epilepsy, weight loss, and migraine. So I think this is the kind of thing, when we use comorbidities in our decision making. So you can use the other three as well, but best one is topiramate. 3-year-old baby boy, severe asphyxia, spastic quadriparesis, focal prolonged seizures several per day, admissions, failed 3 drugs. Then he was started on valproate and clobazam, and what has happened is the status epilepticus has stopped. Admissions have stopped, and he gets some brief focal seizures, 1 to 2 per month, and jerks 2 to 3 per week. EG is abnormal, spikes, MRI showing HIE. What would you do? The question is whether we should go for the ketogenic diet. All of you have heard of it. Go for some palliative surgery. Obviously, you can't do curative surgery over here, but can you do some palliative surgery? Should we add a third drug? Just continue the same medication and just give nasal midazolam as a rescue drug in case of status. That would be the best thing, because over here, the goal is not to stop his seizures. The brief seizures happening once or twice a month are not going to make any difference to him. But disabling seizures and hospitalizations will be already have gone away. So this is the best thing to do, except few seizures as part of the whole illness, and this has to be counseled. 13-year-old non-verbal autistic boy, several episodes of focal non-motor impaired awareness, so what we used to call complex partial seizures, for 2 months, started on levetiracetam. Recently, sleep has become disturbed, has become more aggressive at home and school, episodes of crying, extreme anxiety, MRI normal, EG right temporal sharp waves. What would you do? The seizures are controlled, but behavior has become a problem. So start risperidone, refer to a psychiatrist, change to another ASD, stop levetiracetam, and prescribe nasal midazolam. So this is, people very often start something, go to a psychiatrist, get some risperidone, etc. done. But the thing is, change the AED. That's all it is. Levetiracetam in 40% of patients who have autism or intellectual disability, they will develop a severe behavior disorder, mood disorder, 40%. And the child may have no seizures, but has parents will have no sleep, will be in great trouble. So you need to stop it and change to something else. You cannot stop it and not give medications altogether because he's getting frequent seizures. Which drug would you choose? Valproate, carbamazepine, oxcarbazepine, lamotrigine, clobazam, or topiramate in the same patient. So the drugs which are good, valproate, best, mood stabilizer, rapid titration. Carbamazepine also mood stabilizer, reduces aggression, rapid effect. Maybe you could use that. Oxcarbazepine, similar to carbamazepine, but better pharmacokinetics. Lamotrigine, we remove very slowly. So there's not the right drug to use when you want a quick effect. Clobazam worsens aggression, worsens sleep. Topiramate does the same thing as levetiracetam. So forget about those two. So comorbidities are more important when choosing ASDs. Obesity, failure to thrive when you have a weight problem, weight gain, VPA and clobazam avoid. Oxcarbazepine can also be make you quite heavy sometimes. If you want weight loss, the best drugs to use are topomac and zonazamide. But remember, this is the worst drugs to use in somebody who's already malnourished. The weight neutral drugs are many, so best is to choose from one of them. Levetiracetam, lamotrigine, carbamazepine, etc. In migraine, like I already told you, topiramate is good. Divalproex is good, but in adolescents. So older patients will also benefit with divalproex, which is a salt of sodium valproate and valproic acid. Cerebral palsies, do not use benzodiazepines, nitrazepam, clobazam, etc., because you will increase hypotonia, drooling, and they already have problems in swallowing, constipation, so don't use this. Also, don't use topiramate and zonazamide because anyway they have failure to thrive. What about ASD and systemic disorders? Renal disease, many drugs need dose adjustments, but the newer drugs are quite safe, most of them, especially levetiracetam. So using levetiracetam in any renal problem is not an issue. Hepatic disease, only valproate is important. Metabolic disease, avoid valproate again because of mitochondrial or fatty acid diseases will worsen. And neoplastic, when you're giving chemotherapy or chronic infections, do not use any of the older drugs. Therefore, levetiracetam has become again the most important because it doesn't have any drug interactions. Carbamazepine, phenobarb, phenytoin will reduce the anti-TB drugs or the anti-neoplastic drugs. How fast do you titrate? Let me just say you the flow titrate. Slow titrate is topiramate. If you give fast, the patient will become like a zombie. Lamotrigine very slow, takes 2-3 months, but extremely effective drug. Perampanel also extremely slow, otherwise they become homicidal. Rapid, you can give all these. Valproate, you can give IV, levetiracetam IV, phenytoin. Now, of course, brivaracetam also has come, which can be started straight away, and others. Cost of AEDs, the only ones you must understand is if your patient cannot afford, don't give him newer ones. Give him all these phenytoin, but over here, levetiracetam, of course, is the one which is still very reasonable in cost. Valproate is good. Carbamazepine is excellent. These three drugs. All the others, especially for older patients, the orange is for the cost is for adolescents, and the blue is in the younger patients. In the younger patients, the cost is not that much as compared to adults, but still, look at the number of patients who don't adhere to medications. When you refer to a neurologist, if it's an infantile epilepsy not coming under control, definitely. Drug resistant epilepsy, failing two drugs or more, but you can't really wait for 2 years. You have to refer them as soon as possible because there may be something else you could do, a diet or or surgical evaluation or whatever, which we've been doing in Hinduja for so many years, but we don't get as many patients as you expect. Many patients come late and then the developmental changes, the regression, etc., has already happened, and you may not be able to reverse that. And the last is if you see an MRI, which is lesional, you must send them to a neurologist. Whether the first drug is ineffective, switch to alternative monotherapy. Never keep an ineffective drug on. But if there's partial effect, you can continue it. So how do you know there's partial effect or not? So you have to know, you have to have a seizure diary. If this gap between seizures increases by 3 times, that means the drug is effective. If it doesn't increase by 3 times, that means they're ineffective, and you can withdraw that slowly and add the other one. So choosing an AED is far from easy. Information about the epilepsy, the patient, the AED, and the socioeconomic status goes into the decision. Efficacy is similar in old and new, only ease of use, tolerability, cost and availability issues are important. Evidence supporting AED use is sorely lacking. We are not sure what, because head to head comparisons are hardly there. So, really, managing it is as much an art as it is science. Thank you. Can I put it off?
Thank you very much.
Sir, amazing.
Thank you very much.
Thank you for listening. Tell me.
It was really too good.
Most of the questions that were prepared for you
Yeah.
are probably answered already in your presentation itself. But still, we will continue. We will continue
Is Dr.
with the
Swati here
program.
to start questions?
Yes, sir. Yes, sir. Thank you so much, sir, for the wonderful lecture. And here I would like to invite Dr. C.P. Bansal, sir, if he has any questions to ask from the sir, Rajesh, sir.
Almost all my questions have already been included, sir. But still, for clarification, I will like to put up 2, 3 basic questions.
Yeah.
Your talk was really mesmerizing, I must say. Sir, when should I order for EEG or neuroimaging in a case of first episode of seizure? It includes 2 questions. After how much time I should order? Immediately or 24 hours or 48 hours? and in which child I should order EEG, or as a routine I should order both after the first seizure.
Fine. So let's look at the first one. One thing I forgot to tell you, in the first seizure, you must make sure it's not a provoked seizure. Provoked, what I mean by provoked opposed to unprovoked. Epilepsy is unprovoked. It comes out of the blue, there is nothing else with it. But suppose there's some metabolic or some infection or something of that sort, meningitis, these are all provoked seizures. So once you're sure it's an unprovoked seizure, then this question comes up. If you're not sure, then of course you have to do MRI and EEG, etc. Whenever this happens in a provoked seizure. So let's look at the EEG. So the EEG is not recommended for febrile seizures. Now, question is, I think one of your questions was it a fever triggered epilepsy, that kind of thing. So if there are no risk factors for epilepsy, like a neonatal history or some retardation or some, all those things, and it's only a simple or even a complex, what you call atypical febrile seizure. By the way, the term is now complex, it is not atypical. So complex
Okay.
means it is prolonged. It could be prolonged, it could be multiple, or it could be focal. So these three things, if they are there, even then, EEG very often is not helpful. So and the most important thing in our country is, if you do not have a reliable EEG interpretation, it actually makes less sense to send to an EEG, because you will always get a report of something being abnormal, and then you're forcing yourself to give medication. Because diagnosis of epilepsy is not, or seizure is not made by the EEG. EEG can be normal. Normal kids can have abnormal EEGs, and very often normal changes on the EEG are interpreted as abnormal by many inexperienced electroencephalographers. I'm not trying to say that, there are many good ones now and EEGers, but there are equal number of people who are not very experienced. And that's why, unless you're absolutely sure of your interpretation, you don't have to do EEG in anybody who's got epilepsy with the first seizure. But if you want to be, if you have are trusting, then you should do, because it might help you diagnose an epilepsy syndrome. If your EEG is normal, your risk of recurrence of the first seizure is very low, so you may not start treatment. So if you're sure about your EEG, do an EEG in anybody who has first unprovoked seizure. When do you do it? Usually not in the first 24, 48 hours, unless you're suspecting that there are ongoing seizures. So sometimes, the patient is not waking up or something of that sort, and you're worried about, is the seizures going on inside? Then, of course, you may have to do an EEG earlier. But otherwise, 2, 3 days is good enough. People used to say 2 weeks, but that's not really needed.
Right.
Second is MRI. So MRI is not needed for sure in febrile seizures, unless there's a risk factor. Number two, it's not needed in any self-limiting epilepsy. So how do you know it's a self-limiting epilepsy? That's the whole thing. So you have to get yourself familiar with what self-limiting epilepsies are. One is self-limiting epilepsy with centrotemporal spikes. It's what's called SELECT now, which is called benign Rolandic epilepsy. You get nighttime seizures. I showed you an example, twitching of the face. Usually they're awake. They wake up the dad or mom. They can't speak. They drool, and then they go back to sleep. Or they may have one seizure, generalized seizure, also in the night. So if that particular EEG will show a typical pattern, and the EEG will tell you this looks like a benign epilepsy of childhood. Or there's another type called the benign, what is now called CLES, self-limiting epilepsy of childhood with autonomic symptoms. So they come in the, I didn't show you an example of that, but they come in the night, usually earlier than the children with benign Rolandic or self-limiting epilepsy with central temporal. So they come in between 3 to 5 years, and they vomit at night. So the first thing, sometimes they vomit, they stare a bit and go back to sleep, and you might treat them for gastrointestinal issues, etc. But really, vomiting in sleep and not being aware of it is extremely unusual. So when you vomit, then sometimes the eyes go to one side. They may have jerking on one side. It may be a long seizure. So this is called, and this autonomic term has been given because they vomit regularly. That is the time when the seizure is part of the seizure, and later on they usually have headaches. So this kind of seizure is called CLS, and this also you may not treat, and even this may or may not have a typical EEG. So if your EEG is not typical, if your EEG you're not sure it's a syndrome, if your EEG is normal, then an MRI would be worth it because you never know. Suppose you have a cystic circus. Suppose you have a first episode of a seizure with a, the chances of finding something on MRI are low. So if a patient can't afford it, postpone it. Follow the patient. See if he's getting recurrent seizures, definitely he will need an MRI. So, it all depends on where you're practicing, what kind of socio-economic groups your parents come from. It's very important. I mean, those things, and therefore this is an art. You understand? Because seizures, rarely are symptoms of a severe disease. Sometimes they are, but usually not. So even a follow-up could be enough. You can, if you're sure that they will come back to you for follow-up.
So, however, sir, can I take a punchline that it is, I mean, it is not contraindicated. It is better to be on the safer side if you are sure that it is a seizure, especially if age is less than 2 years.
Yes.
Then we can go for an EEG, provided
The
the report is authentic.
correct.
Sir,
So I
what is
think
the
I think important thing is don't forget to interview the witness. See,
right?
I
Yeah,
always
that is
find
true.
that everybody from pediatrics, when my residents who come to me, everybody's seizure is tonic-clonic isoprolol drooling. But actually, generalized tonic-clonic seizures are extremely rare in pediatrics. They're not common. They're common in adolescents. They bite their tongue, they pass urine, they have uprolling, they jerk, and all this. So, really, if you ask the history, how did it start? How did it progress? How did it end? What happened post-ictally? What are the precipitating factors? Was there fever? Was there no fever? Was there any other symptoms? All these things, you can get a lot of information from the witness. And sometimes the witness is not the parents. But that's why I think important to emphasize to your students that this is what we need to do.
Sir, is there any role of AI in getting reports of EEG?
Uh, the problem with EEG, there's a lot of AI in MRIs. There's a lot of role of MRIs, because the computer can look at scan the image and interpret it sometimes better than the radiologist. Of course, most of the times you don't need it, but it sometimes can misinterpret also. So you need the human hand. But EEG is subjective in the sense it depends on how you do it. The technique of doing an EEG is difficult. There is no training for EEG technicians except in, I think, there's one institute in the south, that is your Sri Chitra, and maybe in Amrita they have a EEG course. But generally, EEG technicians are not well trained. They are basically trained by the neurologists. The neurologists are not trained either. They do EEGs. Their technicians are giving them EEGs when they were training, but they haven't done the EEG themselves. So I'll just give you a thing. When I did my neurophysiology in the US, it was part of my training, 2 years. It was after I finished my neurology. We had to go for the exam and we had to do our own EEGs, 4 EEGs, and take them with us to the examiner over there. And he would look at the EEG and ask us, what is this artifact? What is this? What filter have you used over here? What filter have you? Why did you use this filter? So all these technical things are very, very difficult in EEG. And that's why quality of EEG of the AI will interpret what it reads. It cannot tell you the technicality. That's the problem.
Absolutely. Sir, next is that febrile seizures is okay. We can now differentiate between a seizure and a febrile seizure, but Um, a word about fever provoked seizure.
Yeah, so I mean, the most common one in my experience in India, one is of course it's a provoked by a febrile encephalopathy. So you have to be very careful that it's not something which is a symptom of meningitis or something. And that's obviously applies to the first episode. But if it's a recurrent problem, the question is whether something is there in the brain. So in that situation, if you have a risk factor, this strong family history of epilepsy, not febrile seizures, strong family history of epilepsy, or if you have a child who's got developmental delay, or the child has microcephaly, or the child has some new perinatal problems, then of course you must do it. If there are any motor signs, anything at all, you must do the MRI. And of course, you might think. So, in my experience, the most common cause is neonatal hypoglycemic brain injury. They present very often as febrile seizures. And very often MRI is not done because it's a febrile seizure, which is the correct approach. But then, once the history comes in, if there's something else going on, then you sort of not when the first afebrile seizure comes. So the other important thing is a condition called JEPS. I don't know whether you've heard of it. It's called genetic epilepsy, febrile seizure plus. So febrile seizures occur from 6 months to 6 years. But if a seizure occurs very early or if it occurs very late, you know, after 6 years for the first time, or if you have febrile plus afebrile seizures and you have a family history, very typically that is the condition of genetic epilepsy, febrile seizure plus. So these patients also have febrile seizures majority of the times as the first presentation. And therefore, when you're asking the patient febrile seizure, you must make sure, is there a family history of epilepsy or only febrile seizures? So if it's only febrile seizures, it's cool. There's no problem. But if there's a strong family history of epilepsy, this may be a JEBS plus. And therefore, of course, you may not treat it, but it is you know that the risk is higher for afebrile seizures.
That's great. My next question you have already answered about choice of drug, and the last question from my side was about switching of the drug. You have also said that it is always better to switch rather than to add, in spite if you have very rightly said that if there is some partial response, and you have beautifully defined the partial response also, that frequency of seizures is at least decreased by 3 times. Thank you so much, sir. Only we are in a habit of writing frisium or cloba for febrile seizures, asking the patient to give cloba for 3 days. But you have said that it increases irritability and agitation. So
Yeah, I
should
think
we
for
continue or?
febrile seizures, intermittent therapy is okay. The
Okay.
reason is there are cultural differences between acceptance of disease in the West and in India. That's what I feel after my years of I worked over there. Most people were not eager to give medication. And as long as you have febrile seizures, you told them that the risk is very small, that you will get some long seizure. You take your over there we used to have rectal diazepam, but over here we have nasal midazolam. So you give them the nasal midazolam over here. You know, educated class over here in Mumbai, Delhi, of course, they also don't want to take clobazam. They don't mind the risk. But generally, there's a lot of fear. They don't want it to happen again. So I think intermittent clobazam became more popular. Otherwise, in the West, no, usually people are not using intermittent clobazam. Only over here and other countries where there's a lot of cultural kind of differences, we use clobazam for 2 3 days, and that does cause drowsiness. It does cause irritability, but 2 3 days ka irritability chalega. So that's the thing. You
Thank
can
you
even
so
use a
much, sir.
small dose.
Thank you, sir. That is all from my side. Over to Dr. Swati.
Thank you. Thank you, CP Bansal sir. Thank you, Dr. Vrajesh Udani sir. Now I would like to invite Dr. Anand Ketkar sir for any questions if he's have.
Yes, sir. Sir, most of questions are being answered. My only question is what test should we monitor when a long-term AED is being used, like liver profile, whether CBC or electrolyte? Hello.
Frankly,
Huh.
it's not. See, valproate does give a slight rise in liver functions. That doesn't mean anything. So unless you have symptoms, so if you get symptoms of toxicity, then of course you must do, you must suppose you get abdominal pain, liver, obviously if you get jaundice, or if you get abdominal pain, remember valproate can cause pancreatitis. So you need to do a lipase and a amylase or whatever it is. But if there's no symptoms, just doing routine, it just actually makes it less of a, it just puts anxiety on the parents, I feel. Because it does not mean that he's a slight rise, 1.5 times or whatever. So from 40, it becomes 17. But if it becomes twice, thrice normal, obviously, but then that is usually symptomatic. So unless it's symptomatic, I try to avoid. High dose valproate, definitely I would like to follow the platelet count, especially if there are evidence of purpura and all this. Otherwise, generally, you don't need. In the other drugs, the main question is whether we need to do levels. And the levels have to be done in two. One is phenytoin, you have to do levels routinely. And that means poking the child every couple of months or whatever it is. In the beginning, you may have to do it every month or so, and then later on, every 3 months. That is a phenytoin because the levels are up and down, and the efficacy that it's a very tight kind of between 10 and 20. If it goes below 10, it becomes less effective, and more than 20, you might get side effects. In carbamazepine, sometimes the level becomes less by itself. So, for example, initially you give very low dose and slowly you go up, and then you start the medication. Remember, always start slow, never go very fast. Once you reach your dose, the level may be good, the seizures are controlled. After 2-3 months, carbamazepine commits suicide. So it actually induces itself. And when it induces itself, the levels become half, and then the seizures restart. So there you might want to do it. So carbamazepine, the newer AEDs, lamotrigine sometimes. Otherwise, most of the times, drug levels also are not required in the large majority of cases. The only thing is, what I've realized over the years is that certain, I mean, we have numerous trade names, I mean, companies making the same drug. And we feel that everything should be standard, but it is not. I mean, I've checked that when you use the standard drug, the one which is, say a drug, I won't name names, but say for example, you use levetiracetam, the brand name from international, which is Keppra, and you compare it to the local brands. Usually they're very good, but sometimes just changing the brand from this to Keppra or something makes a hell of a difference. You get efficacy and you may get side effects. So, uh, for example, nowadays there was a drug called Winlep, which is to come in syrup, oxcarbazepine. It's a very good drug, and many patients now Winlep has stopped making its syrup form. Suddenly, the other syrups are not having the same effect, and the levels, in fact, are coming down. So when you're not sure about certain things, why is the seizures come out of control? Why is there a breakthrough seizure? Is the patient taking medicines properly? All those things that way, I think you could do a level. Although generally drug levels are not required for most of the times and most things. Otherwise, topiramate and zonisamide, you might require routine ultrasounds every year because they can get stones, renal stones. But generally, most of the times, you just need to follow the seizure. And one more thing, never increase the dose just because the weight has gone up. Because the variation of the dose which is going to control the seizures is different in different patients. So, very often patient comes here, अभी 3 kilo बढ़ गया चलो dose बढ़ा दो. Absolutely not required. Go on the control. Control is not there, go up. And don't go to supernormal doses. if you're going to normal doses, and then normal doses also have to be known because so many drugs are there nowadays. You should know them. Usually, you will get effect. For example, levetiracetam, 90% will respond at 20 to 30 milligram per kilo. It's only occasionally that 10% you may require to go to 50 milligram per kilo. For example, clobazam, you may require half a tablet to control, or you may require 3 tablets or 4 tablets to control. So it's such a variation. So you start slow and you just titrate according to seizure control or according to side effects. If the side effects are, say, getting side effects at this dose, then you cut it down slightly, that kind of thing.
Okay.
So it has to be, more of that way.
Sir, in our era, Gardinal and Phenytoin were used and they were quite effective. Nowadays, it has been replaced by levetiracetam and lamotrigine. How long time use is safe in children?
Which ones? The phenobarbital,
No. I
or
mean, these newer drugs, levetiracetam and
very,
lamotrigine.
very safe, very safe. That is the levetiracetam, for example, except for the behavior side effects, the other side effects are unusual. There are everybody can get side effects. For example, they're very rare. I mean, they're very common side effects which are not realized. I mean, one of the side effects of levetiracetam, which is repeat recurrent nasopharyngitis. So your child keeps getting
Okay.
cough, cold, cough, cold, cough, cold. You keep giving him allergy medications. You give him antibiotics. And all. The actual reason is levetiracetam. You understand? So there are rare side effects, but generally safety-wise, in the sense skin rash, Steven Johnson syndrome, renal failure, hepatic, cardiac toxicity, all those are very low. Levetiracetam doesn't even have toxicity on the cognition, but has a severe problem with behavior. And therefore, you avoid in patients who already have a behavior problem. That's what I'm saying. It will definitely worsen him.
Okay. Thank
Lamotrigine is important for skin rash, and that skin rash occurs quite frequently. Therefore, you go very, very slowly, especially if you're using it with valproate, and you have to use it very, very slowly. Skin rash will occur only in a small percentage, but can be damn dangerous. You can have a Steven Johnson syndrome. For example, uh, people start half tablet. You have to start as low as zero point 0.2 milligram per kilo in valproate when you're giving valproate along with lamotrigine. So a 10 kilo boy, you have to give 2.5 milligram. So I'll tell you a story. Once I had a patient, I that time I told them 5 milligrams. So I told him to please cut the 25 milligram into four and give quarter tablet. So I wrote 5 milligrams, 5 to 6 milligrams starting dose. There was no 5 milligram tablet. Oh, there was a 5 milligram tablet, lamotrigine, Lamitec. So I wrote Lamitec 5 milligrams, give half a tablet. They went to the chemist. The chemist said, ये 5 milligram है ही नहीं, ये 50 होगा. So he gave him half a tablet. He got a Steven Johnson's rash the next day, was admitted to another hospital, and died over there.
Oh,
Imagine, died over there. And that patient, doctor can inform me that you have given this patient a high dose. Luckily, I had my paper with me, which said 5 milligrams. So then I contacted the company. I said, you have to change this 5 milligram, you make it Lamitec Kid. So they made it Lamitec Kid. And that became Lamitec Kid 5 milligrams. Problem is, their sales were not going up. So they've withdrawn the 5 milligrams. So now you're back to lamotrigine 25 milligrams. And the same problem persists. This is the issue.
Okay, sir. Thank you. Back to you, Swati.
Dr. Swati, can I have a question for sir? I'm Dr.
Arey,
Ajay Gaur.
welcome.
Yes,
Welcome,
sir.
Professor Ajay. Actually,
Sir.
I never
Sir,
realized you have come
I'm
back so
no sir.
soon.
I'm in travel, but I could not resist myself after listening to Dr. Vrajesh Udani, sir. Excellent talk, excellent presentation, and so many practical tips. Sir, what is your experience with this cannabidol, the newer drug, particularly in West
नहीं
syndrome
नहीं
and in
वरचे
refractory?
Uh,
Hello.
Well,
Yes.
the first thing is that it's pretty expensive. So it has to be used in the sense in patients who can afford. It's about 7,000 rupees per bottle of 60 ml, I think. And it comes to 100 milligram per ml. So it lasts for about 10, 12, 15 days. It's good drug in some patients. It's not as fantastic as the literature and the companies tell you. And it works particularly well with with clobazam. So if you have clobazam on board from before, you have to cut down the dose of clobazam when you start it, primarily because it increases the dose of clobazam and the patient may go into some sort of drowsiness and all that. So we reduce it slightly, the clobazam to say three-fourth of the original dose, start the CBD, and people are using very small doses. So you
Yes.
start with 2.5 milligram per kilo, you go up to 5 milligram to a maximum of 10. Sometimes you may require higher, but 10 is the usual highest dose. And that would be, say a 40 kilo child is there, and you're giving him 10 milligram per kilo is 400, so it's 4 ml per day. So in 15 days or something, it'll be over.
Sir,
The,
how long? How
that's
long it can be used once it is started? I have one kid.
long time, long time,
Long
long
time we
time.
can use it. Okay. Thank you, sir. Thank you, sir. But it has got a wonderful result, sir. One of patient who is already on three antiepileptics, and just on fourth day of giving this drug, his all the seizures are subsided, and I have tapered the other doses also. So
Good. Yeah, so it's like, any of these drugs. Uh, all these drugs sometimes are phenomenally effective and sometimes they're not. So, and sometimes there may be a honeymoon period, which you should also know that it might last for 3 4 months, especially in drug resistant epilepsies. There's something called the drug resistance. So there are some certain proteins in the which actually throw out the drugs. They actually, I forget the name, P something, where they actually expel the drug because they consider the body considers the drug as a outside toxic agent. So your effect may be there for a few months and then again it comes back. But I think CBD should be used judiciously, no question about that.
thank you, sir. Thank you, sir.
Thank you,
Sir, I
sir.
want to
Sir,
I wa-
uh,
a question.
hello.
Hello,
Yes?
Nisar sir,
hello.
Nisar sir,
Yes,
I
sir.
Hello?
want
Yes, sir.
to ask one question.
Nisar sir,
Yes, sir.
our
Yes, sir.
questions
Please.
are already in queue. Please wait.
Okay, okay.
Uh,
Ji.
sir, I have one question. As you said, hello.
Yes,
Yeah.
yes.
Hello. As you said, sir, that recurrent pharyngitis can be a side effect of levetiracetam. So, in that case, if the epilepsy is well controlled on levetiracetam, should we need to change the AED?
Well, see, side effects are generally the side effects, the way you look at them is they are very often transient. So if it's a persistent side effect, it's causing a lot of grief to the patient and a lot of disability because of the nasopharyngitis and all that, then maybe you can think of switching. And now there's a newer drug which is brivaracetam, which is a
Yes, sir.
higher, second generation levetiracetam, which
Yes.
has less side effects. So you can try that because that usually,
Okay.
if the levetiracetam has worked, this will also probably work, and you
Okay.
can use that rather than stop the drug completely.
Okay. And sir, one more question, that how long we should use anti-seizure medication in case of like post head injury patient, post meningoencephalitis patient, and neurocystic psychosis.
It's a good question, and the answer is a little complicated. So, in trauma or in meningoencephalitis, these are acute symptomatic or acute provoked seizures, and so there are two types. For example, you have a trauma, you have an immediate seizure. You forget about that. That is usually part of the concussion. Then you have an early post-traumatic, which comes in the first week. And then you have late post-traumatic. Now, late post-traumatic is usually epilepsy. Early post-traumatic is provoked. Most of the early post-traumatic will not go into epilepsy. So the incidence is between 5 to 10% will go into epilepsy. So usually you don't need to treat for more than a month, 2 months, maybe maximum 3 months. There was a study which showed that the efficacy
Okay.
of anti-seizure medication in trauma is really 1 week, the first week. Because after the first week, if you don't get a seizure, you're not going to get a seizure. But if you got a seizure, then you continue for a month or 2 months, no problem. People are giving it for years, which is absolutely wrong. So maximum you
Sir,
can use in these kind of situations where you have a yeah. Sorry.
in one of my patient, post head injury patient, like after 2 months of seizure free period, he was on already on anti-seizure medication. He had seizure again and some focal discharges in EG as well. So in that case, for how long we should use like
Yeah, so that is most likely late post-traumatic seizure. So that case actually typifies that giving prophylactic anticonvulsants or anti-seizure medication is not going to prevent late post-traumatic seizures. If they're going to happen, they're going to happen, and then you have to deal with them according when they happen. So if once you
okay,
diagnose epilepsy, especially if it's a post-traumatic or post-meningoencephalitis epilepsy, then you're talking about a long, long haul because these patients often have damage. They often have maybe they may have a little bit of drug resistance. They may have drug-resistant epilepsy. They may have so they may at least I would use at least for 4 years before even thinking of stopping. 4 years of no seizures. So the seizures keep coming back, then you can't stop for until the seizures are completely controlled for 4 years. And the EEG shows that the chances are, I mean, the EEG is almost normal, then maybe you can take a chance. But remember, we did a study on perinatal brain injury, especially NHBI, and we found that only 4% of patients who were controlled on medication, there were about maximum, there were 40% patients who were controlled on medication. Out of that, only 4% we could stop the medication. The remaining
okay.
patients, you stop the medication, it will come back. So, it all depends on the etiology. But for self-limiting epilepsy, you would give it for 2 months or 2 years because you know
And
that
what
it's
about
gonna.
meningoencephalitis? What about like post
No, but
meningoencephalitis?
all these trauma, meningoencephalitis, etc., are basically the same. They are basically brain insults. NCC is a little different. The NCC can come, you can have an acute provoked seizure when there's edema around the NCC cyst. That will subside as soon as the edema subsides. Then the second type is that after the edema, so that you may use epilepsy, anti-epileptic drugs, anti-seizure drugs for 6 months.
Okay.
And if you find that now it has become calcific or at the end of 6 months and all the thing has gone away completely, then you can stop the medication. Now suppose it is still there and there's calcification, doesn't matter. Then a small group of patients, the seizures keep coming back whenever there's edema. So the same calcified uh, cyst, which is supposed to be inactive, keeps becoming active every few months or few years. There is a problem because you don't know when it's going to become active again. And why does this happen is not very clear. It may mean that as the cyst degenerates over time, there's some chemical reaction and all that kind of thing, and something is forming over there. The third type of seizure you get in NCC is that you actually get gliosis around the calcification. Then it becomes like any other epilepsy. Then you
So
have to use it for at least.
do we need to give albendazole again and again in case of
No, 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 no. Once you have uh, calcification, there is no need to give albendazole again.
and sir, one last
Calcification
question.
means it's gone.
Okay. And sir, one last question. I have a patient with very refractory kind of breath holding spell, and he's already on piracetam and levetiracetam, but this is not like completely cure is not there. He's improved. He's very much improved, but complete cure is not available, and the parents are very much apprehensive. So, what should be the like next line of treatment?
Well, frankly speaking, there is no, most breath holding spells you require counseling. So if it's very severe,
Yes,
if
sir.
it is sometimes can be followed by even seizures for a long time. So we've seen breath holding spells which are very severe. Sometimes there's a seizure which goes on for 15 minutes. So in those situations, like you said, you can use levetiracetam. Piracetam is of course has been tried. Levetiracetam, as far as I know, has not been used as a drug in this, but it's the same group, so it might help. But in if it is already improved a lot, you just counsel them. Then it will go
Okay.
away in the matter and give iron and calcium and all this kind of thing.
Okay.
And
Thank you so
deficiency has
much,
to be,
sir,
of course,
for the
treated.
wonderful explanation. There is a long list to ask, but due to the lack of time, I would like to
Yeah,
invite Dr.
thank you.
Suhas Donde, sir, for
Thank you
the
very much.
questions.
May I request Dr.
Swati, Dr.
Sudha?
Nisar sir
She has.
has some question
Ah,
to ask. Dr. Nisar,
yes, sir.
please.
Yes,
Uh,
sir.
And then
Yes, sir.
uh,
Dr.
Thank you, sir.
Sudha has
Sir,
written a question in the chat box.
Yes, sir.
my que-
Nisar, sir, are you there?
my question to sir is, sir, in what conditions or what situations we should use multiple drugs, and how many drugs at a time we can use? Because I have seen so many neurophysicians, neurosurgeons using multiple drugs.
No,
Sir,
in what situation you use is basically the way I look at it like this: you start the first drug, no control,
okay,
but
okay, sir,
partial control. Say no control, then you switch to a second drug. If some control but not full control, you add a drug. So that's
okay,
called
sir,
rational duotherapy. After two drugs, if it continues, then he technically becomes a drug resistant epilepsy.
okay, sir,
Drug resistant epilepsy means you should now, if it continues, say for a year or two, in children, the exact time is not defined. So you check the development. If the development is going down or something, then it should be pretty fast. Don't wait for 2 years. But in older patients, 2 years is the norm. Maybe you have to send him to a center which deals with epilepsy. Neurology and epilepsy is a sub branch of neurology. So a comprehensive epilepsy center is a center where you actually do everything. You manage drugs, you manage the diet, you manage epilepsy surgery.
okay,
You
sir,
can do what is called high resolution MRIs, and you can do PET scans, and you can do SEEGs, and you can do all those things.
sir,
That has to be done. So pre-surgical evaluation has to be done. And if it is then negative, then come back and then you can retry the drugs or whatever it is. Usually we don't, suppose you nothing is there, nothing is surgically possible, diet is tried, it's not helped, then maybe you can go up to a maximum of, I would say, 3 or 4 drugs, never more than that. If
okay,
you're
sir,
going beyond that, that means you're not removing what you already added. That's what I'm saying. If you have a diary, so how do you tell? You have to have a diary, no? If the patient doesn't tell you कि अभी आज ये महीने में 6 आया और लास्ट महीने में 3 आया and now अभी 10 आ रहे हैं 12 आ रहे हैं, how do you know it's increasing? Because they come and say चल रहा है चल रहा है चल रहा है. You
okay,
have to
sir,
give a number to it and to realize whether your last medicine change has helped or not helped. If it has not helped, then remove the drug. Don't keep
okay,
it
sir.
on.
Thank you, sir. Thank you very much, sir.
I think Sudha had a question. I don't know what.
Yeah, okay. I think I'll ask it. I just wanted to um, take your comment on the pharmacogenetics and the role of choosing an AED. How far are we in tailoring?
Well, yeah. So there's a group of monogenic epilepsies, which you see in mainly in the first year of life, which typically the children with bad epilepsies, they have developmental delay, and they have all sorts of other problems with them. And they can be, now they've been found in a particular gene, either a sodium channelopathy or a potassium channelopathy or some other problem is there, and you can now come to a conclusion pretty rapidly with the use of whole exome sequencing, etc. In that, there's an expanding list of new drugs which have been used. So, to give you examples, the most common syndrome is, of course, Dravet syndrome, which is SCN1A, is the gene, and you get a mutation in the inhibitory circuits. And because you get a mutation in the inhibitory sodium channel circuits, if you use sodium channel blockers, it will increase the excitation and therefore you will get more seizures. So you know that you can't use sodium channel blockers in Dravet syndrome. And they come with febrile seizures, usually on one side or on the other side. And they look like focal seizures. Then you can use certain drugs. For example, CBD oil has been approved. There's a drug called fenfluramine, which was used in obesity in the past. It's very effective. The stiripentol, very effective. But these drugs are, except for CBD oil, they're not available. So in India, we use topiramate, we use CBD oil, we use Zonegram, we use Frisium, and we use valproate and diet. Then, for example, SCN2A, so the ones who come before 3 months, and you diagnose them, so they have seizure onset in the newborn period, they have very bad seizures. You get the SCN2A, you give them sodium channel blocker, it's a miracle. They just stop seizing immediately. They have 40, 50 seizures a day. You give them small dose of, not small dose, but phenytoin or carbamazepine or oxcarbazepine, they stop seizing. So there have been, and now there are many whole list of things you can do, pharmaco. So what is called but precision medicine. But this is still 1% or less of the general epilepsy pool. That's why. And there's also one more thing about she's asking about personalized AED tailor-made. That can you can also do it. For example, we don't use carbamazepine in those who are HLA-1502 positive because the risk of Steven Johnson's is high. Then there are things like valproate, they're slow metabolizers. So you give those patients valproate, they get very high levels very fast, even on low doses. So phenytoin also same thing, slow metabolizers and all that. So all these things can be now tested. There's a test also where you can get 256 drugs checked, including all the anti-seizure drugs.
Thank you very much, sir. May I now request Dr. Dinesh Ladoya for his comments. Dr.
Thank you,
Dinesh?
Suhas. Am I audible?
Yes, you are.
Thank you, Suhas. Am I
सुहास पहले
audible?
दिनेश के बारे में तो कुछ बोलो, उनकी यादें दिलाओ जरा.
मुझे लगता है पहले वो बात कर ले, समय बहुत थोड़ा बचा है.
अच्छा.
Dr. Dinesh. Hello. Dinesh sir.
Dinesh, you are not audible. Unmute yourself. I think there is some problem here. Unmute yourself. You are muted.
Yes, am I audible now?
Yes.
Yes, you are.
Hello? Am I
Yes,
audible now? Yeah, it is so thank you, Suhas. It is so fortunate to hear on a complex topic like epilepsy straight from Professor Udani. In a small little time, he explained everything, right from how to diagnose, seizure mimics, his experiences, the management, and the complex issues. We are very fortunate. Thanks, Gwalior ki puri team ko, Dr. Kep sir, Dr. Banga sir, Dr. C.P. Bansal, Suhas, Dr. Sudha Roy, Professor Gaud, or Dr. Kiran Agrawal ma'am, Dr. Sati, everybody, there you are doing an excellent job in propagating science. Please accept my heartfelt thanks for all these things. Thank you. Dear.
My pleasure. Thank you very much for inviting me. Thank you.
Thank you.
A word from
Yes,
Dr. Sudha also.
Sir, can I ask
Dr.
one more question if the time permits?
Yeah, please, Swati.
Sure.
Sir, in case of focal epilepsy, focal seizures due to the focal cortical dysplasia, the patient is already on 3 anti-seizure medication, and there are some subtle seizures, frank seizures are not there since 1 or 2 years, but he's having subtle seizures. So do we need to escalate our treatment in that case if the
Yeah,
EEG is normal?
you need a pre-surgical evaluation.
um, Despite to pre-surgical evaluation, because the patient is not ready for the pre-surgical evaluation. And
Well, then depends on the disability. So you say subtle seizures. I mean, what do you mean? Is it that? See, I
um,
mean,
like
FCD as a rule, general rule, are drug-resistant epilepsies.
दीपक उग्रा से भी
They
बोला
sometimes they can come under control, and I'm not saying no, but that's usually temporary control, 2 3 years or whatever it is, and then things start again. And what happens when you in these FCDs, which are basically malformations of the cortex, is there are many unrecognized seizures. So if you do the video EEG, or there's something called now, something called RNS and all, where you actually do a continuous EEG. RNS is a responsive neurostimulation, so that contains an EEG chip inside, so you can actually see they get hundreds of seizures when you see 10.
okay,
So what happens is over time समझ कम हो जाती है. You don't
okay,
realize it. So I think they need, if there are seizures going on, they need.
yeah. Thank you, sir.
May I request Dr. Deepak Ugra? Deepak, are you
Sir,
there?
I have, yeah. I have already written my statement. He's excellent. There is no doubt. So from the very basics, when I was hearing all his slides or PowerPoint, uh, no doubt that I was thinking like I'm managing. I can visualize the clinic and managing the epilepsy clinic so easily. It was so easy. I never knew, and it's amazing. I'm his fan. More than that, you
Yeah.
see, when Sudha asks a very specific question, what is the depth? Where he has taken the discussion? So you have very basic, because you know who are the audience who are listening, and if somebody is asking a very specific question, he can take you to the depth. That is what is quality. I'm amazed. Vrajesh, thank you so much.
Thank you, Deepak. I mean, I'm honored. Thank you.
Thank you very much. Dr. Ketkar, sir?
नहीं डॉक्टर सुधाराव first.
Sudhar.
Yeah. Thank you for this opportunity. And I'm indeed honored to be called to listen into this session as a guest. Dr. Udani, like you heard in his CV, he visits Wadia Children's Hospital. And even before him coming to Wadia Children's, I knew him right from my Kota days. After finishing my MD, I had gone to Kota in Rajasthan, where I was working with Dr. Rajeshri Singhania, his sister, who was running a hospital called the LSS Children Hospital. And it was the first experience of mine working in an exclusive pediatric hospital, which shaped my way. And Dr. Rajeshri was from Wadia, and I could meet Dr. Udani in her house in one of the CME's conferences, and she used to invite him quite often, and that was a pleasure always to interact with him. And after I shifted to Wadia, the first thing, I was a lecturer when I shifted to Wadia Children's Hospital. And as usual, lecturers were given a choice which specialty to choose. As in, they would go to all specialty clinics and then finally find a bearing in one of the specialties. And I remember going to neurology OPD and with Dr. Surekha Rajadhyaksha also looking at the EEGs. And by as fate would have it, somehow other people joined, and then I moved on to endocrinology because there were some changes which happened at the top end at Wadia Children's Hospital. So I love the way you teach, sir. There is no need to speak it out in sentences or words like that. It's been always a pleasure to meet you and interact with you. Just a few words I'd like to say to this audience of children. Now I head at the institute as the medical director. I'm really thankful to all the support everyone has shown me through my journey these years ahead. It looks like so long ago. I came out of GRMC in 1991, December, to be precise, finishing my MD. So now at Wadia Children's Hospital, this is the 525-bed exclusive pediatric children hospital in our country, which caters to fetal intervention, surgeries, diagnosis, treatment, going on to newborn care, one of the biggest neonatal units we have in our country, which is about 150 beds. Then going on to various pediatric super specialties which are available. There are about 37 super specialties, pediatric super specialties, which are available at Wadia Children's. And going on to transitioning these children to adolescence and then adulthood is the spectrum of care that we provide. Today, we concluded our NABH surveillance meeting. I was happy. It is also an accredited center by NABH. And the journey goes on. Thanks to the blessings of my teachers, Dr. Belapurkar sir, Dr. Shingvekar sir, and Dr. Thavrani, and my senior stalwarts in the Indian Academy of Pediatrics and Pediatrics like Dr. C.P. Bansal. Dr. Deepak Ugra was the person who was actually responsible for my visibility in the pediatric arena at the national level. I'm thankful and grateful to all of them for giving me this opportunity and an opportunity to prove if I could do better. And welcome you all to Wadia Children's. Anytime you all walk into Mumbai, please drop into Parel Wadia Children's Hospital. It will be a pleasure to show you all. Thank you.
Thank you so much,
Thank you
sir.
so
We are
much.
really proud of you. Sir, we organize this and we invite two of our alumni from the department
Yes, I
in
know.
every episode.
Yeah. Yes, yes. No, I just want to pay my respects actually to one of the great Wadia stalwarts, Dr. Rashid Merchant, who unfortunately passed away just a couple of days ago. So I
Yeah.
take this opportunity to extend my condolences to his family, and I think, we've lost uh, a very big man in pediatrics, and he'll be missed. Thank you.
So, yeah,
Dr.
we
Ketkar,
are
sir,
going
for
to
Okay.
formal vote of thanks.
Yeah.
just
I
1 minute.
take
Yeah,
We would
Dr.
be
Sudha.
sure.
Yeah, please,
we,
Sudha.
sir, just to read, we would be conducting a prayer meeting on Wednesday next week, and I think it will be online as well. If
Oh,
people
great.
interested can join in.
Yeah, yeah. Thank you.
Sir,
Okay.
I have heard
So
your oration of Dr. Merchant also and of Dr. Anand Chandil's oration also on Dr. V. Merchant, sir. That was also too good. Yes, Dr. Ketkar, sir.
so I take opportunity to conclude this insightful and impactful webinar today. First and foremost, I would like to extend our deep gratitude to the guest great and guest speaker, Dr. Brajesh Udani, for sharing invaluable knowledge and expertise. Sir, you enlightened us. Your discussions have not only enlightened but understanding and have inspired us for more practical in public. My heartfelt thanks to our guests of honor, Dr. Sudhara and Dr. Dinesh Lauria, for sparing valuable time, especially on this Sunday evening. We have taken a lot of time of yours. It will be a great mistake if I don't acknowledge the efforts taken in organizing this webinar, especially to the CP Bansal, Ajay, Suhas, Swati, and I extend heartful thanks to them and to all GAP Parivar. And to end and in end, I just want to extend my thanks to the all viewers, without whom it wouldn't have been a successful event. Thank you so much.
Thank you.
Thank you
Thank you,
very
sir.
much.
Thank you so
Thank you.
much.
Thank
Okay,
you.
Sir,
good
we will
night.
Thank you,
try
sir.
to
Thank you,
prepare
sir.
a short keynote messages from this talk and then we'll send them to you for approval and then we'll share with the group.
Sure, sure. Thank you so much.
Thank
Thank you.
you.
Thank
Good
you,
night.
sir.
Bye. Good evening. Bye.
Thank you,
Good
Sudha.
evening. Bye bye.
Good evening.
Good evening, sir.
गुड इवनिंग। रुइया साहब बहुत फॉर्मल बोल रहे थे तुम, चले ही गया अब तो। चलो दीदी चरण स्पर्श।
Thank you very much for a wonderful
ठीक है.
time. ठीक है. Looking forward.
Okay.
Thank
Okay.
you.
Now looking forward for the next webinar.
For the next webinar.
सुहास, थैंक यू फॉर टाइम मैनेजमेंट, गुड
Thank you.
टाइमिंग।
Thank you.
तुम्हारे दो दो जगह कैसे नाम आ रहे हैं सुहास? चलो सर, वो की नोट मैसेजेस बनाने हैं डॉक्टर स्वाति, और आप यूट्यूब पे सुन के बना सकते हैं। चलिए सर।
ठीक है.